I am clearly not in New Jersey, nor do I sound like I'm from New Jersey. I am in Charleston, South Carolina, where it's a wonderful 68 degrees this morning. So I hope you all are feeling the mild weather. We here at the James B. Edwards College of Dental Medicine have a mighty team in the Division of Population Oral Health. My colleague, Dr. Nelson, will be speaking in one of the breakout sessions. Our division is focused on addressing a lot of the oral health inequities that our state faces, with an emphasis on children and rural and other vulnerable communities. And what I'm hoping to share with you today is what those investments look like from a systems development perspective. So I'm going to introduce to you and really tee up the breakout session by contextualizing what's happening in rural children's oral health nationally, give some insights into what we've been working on regionally through school-based programs and the cultivation of local rural champions, and then how those pieces are coming together for systems purposes. So again, I do not want to steal the thunder of my colleagues who will be presenting to you later this morning, but we collaborated with our friends at the South Carolina Rural Health Research Center, and in the middle of the pandemic, we're brave enough to talk about children's oral health in rural America and the policy levers that need to be pulled to address those inequities. And doctors Joni Nelson and Elizabeth Crouch will share that data with you later today. What I wanted to tee it up, though, is say what we did not expect was the media attention that came from this paper. We thought releasing this in the middle of a pandemic, no one would be interested, but it was the antithesis. This paper was in the top 5% of all papers published with regards to getting media attention. That was reaffirming to us, not because we're necessarily excellent writers, but that there are constituents out there who care a great deal about rural kids and their oral health. So I'm hopeful that that reaffirms and validates your own passions and dedication to addressing rural oral health in New Jersey. So what have we been doing? Well, we have formed public, private, and academic partnerships to address school-based oral health, thinking about inequities in our own state and in our sister state in North Carolina. We felt like one of the most strategic things that we could do is to bring comprehensive school-based programs to our rural communities. We had big hopes and dreams, and they were fortunate enough to come to fruition. We leveraged partnerships with our sister School of Public Health at East Carolina University. We accepted the leadership of the Duke Endowment, which is our region's largest philanthropy, who was good enough to pull in funding partners from the Blue Cross Blue Shield Foundations of North and South Carolina. Together, they have dedicated $35 million to proliferation of school-based programs in North and South Carolina. We started this work 5 years ago, and I am very excited to share with you that we are now serving almost 400 schools across both states, thanks to this wonderful investment and the thought leaders from our academic institutions and colleagues and thought leaders in national areas. So this has been a tremendous gift, but it has not solved all of our problems, and I will unpackage some of this. Even though the school-based programs, despite COVID's best efforts to thwart it, are moving well. Dr. Nelson led a study with some of our key partners to really hear from school nurses to get better understanding, at least in South Carolina, as to how can we build on this new infrastructure that we've brought into schools. And in the survey that she led of school nurses, what we found is while we can bring access to care, we can bring dentists, we can bring services, It is not the panacea for the inequities that our rural children continue to experience. So if you look at the bar graphs at the lower half, what you see as the real challenges that our school nurses in rural schools are facing aren't problems with getting dentists. It is many of those enabling elements, such as language barriers, affordability of care, parent engagement and follow-up, and transportation. And so this was wildly helpful to us in thinking about systems, not just bringing providers into schools, but how do we grow that into a true system that serves the needs of rural children. So that brings us to the sweet spot of these comments, and that is the work that we're doing in Marion, South Carolina as a Sentinel community to pilot test the development of an integrated system of care that addresses the needs of rural children's oral health. So just community context is very important to us in our work. We are health services and policy researchers by training, but we are also community engagement specialists. And just a couple of notes about Marion so that you have a better understanding of our opportunities and challenges. In its heyday, Marion was the bedrock of the tobacco industry on the eastern seaboard. Marion is located on the I-95 corridor in our state, almost to the North Carolina state line. If you've ever visited our beautiful state and been to Myrtle Beach, you've only been about an hour and 15 minutes from Marion. Tobacco is an interesting community element. While those of us in public health hear tobacco and think of the ills of tobacco and its threat to public health, tobacco is really an important component of this community's identity. So as we're coming in, certainly as oral health professionals, we have to be mindful that tobacco conjures up different connotations for members of this community that are different and sometimes in conflict with what we're espousing. It is the marker of their economic prosperity that was taken away from them when big tobacco pulled up out of the US and went to other countries. So these are wonderful people. It's a great community, but we have to respect and acknowledge that tobacco is a part of their community identity and fabric. So with that in mind, also appreciate that we see the unfortunate population health impacts of tobacco on that community, not just from a chronic disease perspective, but from an oral health perspective as well, which makes this a really interesting and complicated place to do this work. But this graph I'm going to walk you through expeditiously, being mindful of my time. We start with the school-based programs and those investments from our philanthropic friends, and we have two really great programs that we're working with. One is a hygiene program in the Marion County schools. The other is in Johnsonville, South Carolina, which is just across the county line. Technically, it's in Florence, but economically and culturally, they are aligned with Marion County. That particular school system is served by a community health center called Healthcare Partners. So we've got services in schools, which is great. We also have another investment. It turns out that we had a great opportunity that meant that our healthcare system, the Medical University of South Carolina, bought the hospital in Marion. We also acquired the physician network that was affiliated with that system. So we are now co-locating hygienists in the pediatric rural health clinics that we have there as a way to reinforce an integrated approach to addressing pediatric oral health disparities. We are also working closely with community dentists. So you see lots of arrows, and basically what I just want to summarize is we have private practice infrastructure, we have school-based infrastructure, and now we have the co-location of hygiene and primary care infrastructure. So We don't have an access to care problem in Marion County right now. In fact, we have a blessing of riches that requires some really sophisticated care coordination and management. So we have created and received funding for new infrastructure that directly responds to the feedback we got from school nurses, in that we need help with care coordination and helping families address the enabling service needs that they have. So we are calling it the COIN. It is the Community Oral Health Integration Navigator. She is going to work directly with our MUSC team, as well as the community dentists and our school-based partners, to ensure that kids are getting into the system, they're getting properly triaged, they're getting treatment plans, and they're ending up at the appropriate places of care, whether it be in school-based programs or in community dentists. So we're very excited about the choreography of care, and that there are built-in redundancies of how kids can come into this system. What is missing is some specialty needs. Here in Charleston, Charleston sits about 2 hours and 15 minutes away from Marion. We have a large OR system here, and what we have seen here in Charleston is a high volume of traffic from kids from this region of our state in need of surgical intervention before we can move them into a place of oral health wellness. So what we have prioritized and received funding for is to take our pediatric dental residents to the hospital we now own. We are leasing an OR suite, so we are able to bring a value-added specialty need to that community that is missing. It will be very important for us to work collaboratively with the COIN, that navigation person, so that as we're providing OR services to keep the kids in their own community, that COIN is going to make sure that the follow-up that's necessary is happening, whether the patient be a patient of record with community dentists or one of the school-based programs. And by the way, the other constituent who wins in this model are our own pediatric dental residents. Being here in beautiful Charleston, South Carolina, they rarely get to see what life looks like in a rural community. So we're very excited for them to get this cultural and this community experience while also honing in their surgical skills. We're also developing new training programs that will have built-in rotations. So again, we're exposing both pre-doctoral students as well as students in specialty areas the opportunity to see what life is like in a rural area, in hopes that we will continue to recruit young professionals into communities such as Marion and keep them there. So watching my clock, we're very excited about the success of this model, and our hopes is that we will be able to use the Sentinel community as an intended pilot, but for replication in other rural areas in North and South Carolina. So quickly wrapping up, our success is evolutionary and not linear. So I say that to encourage you all as you think about how you might also want to build systems and bring new access. Take the wins, know that there'll be setbacks, but those setbacks are opportunities for quality improvement. So don't be easily deterred. What we are observing is that truly sustainable systems are greater than the sum of the parts, especially when it comes to access to care. Please, please remember that access alone doesn't solve the problem. You have the many enabling components that also need to be factored into those models. Rural oral health systems are dynamic, and non-dental providers have an essential role in championing that cause. We have found that school nurses are our best change agents and advocates for oral health. And last but not least, at least in South Carolina, our oral health inequities are so big that we couldn't possibly legislate our way out of it with good public policy. It absolutely requires investment of public, private, and academic leaders to make this type of work successful. So thank you for giving me the opportunity to share the work that we're doing. And